Hi, everybody. We are going to talk about the 3Ds, delirium, dementia, and depression. You may ask when we're talking about all of these three together, though delirium and dementia appear very similarly, but we've also found some very common findings with depression in the elderly population. Delirium is considered an acute disorder of attention and functioning. Often the patient may be aware of the change taking place within themselves, and they may say something like, I feel like I'm losing my mind. What they found from a physiological standpoint is that the neurotransmitter acetylcholine and possibly dopamine are somehow greatly and suddenly reduced. Of course, this is preventable and it is treatable, common in hospitalized patients. One of the characteristics is a sudden onset. It may fluctuate throughout the day, and you cannot explain it by pre-existing neurocognitive conditions. It tends to last 1 to 7 days, but it can last up to a month. It can occur at any age, but it's more common in the elderly population. 7 to 61% of older adults, I believe it's closer to that 61%, experience it during their hospitalization. This is the DSM criteria for delirium. Again, a disturbance of consciousness. They have a decreased awareness of their environment. They really can't focus or keep their attention. They may have some memory deficits, some language deficits, some disorientation. They may have some perceptual disturbance, such as hallucinations that's not accounted for by another diagnosis. This usually develops over hours to days and just tends to fluctuate during a 24-hour period. Some of the risk factors for delirium, of course, are having pre-existing dementia, because you can have delirium superimposed on dementia, which makes it really tricky to diagnose. And those who do have pre-existing dementia and develop delirium often do not return to their baseline. Anyone with any sensory impairment, sleep deprivation, any serious medical condition, infections, a lot of medications, if they are already immobile or have diminished ability to take care of the activities of daily living, any imbalance in their urea, their electrolyte imbalance, or severe malnutrition can predispose somebody to delirium. We want to look at identifiable causes for delirium and treat those. First, you want to look for, is there a general medical condition that may be causing this? Some kind of hypoxia, dehydration, is it sepsis? Is it some severe comorbid condition such as hepatic encephalopathy? Is there a neuro cause, renal? Any of these are identifiable causes. Look for substance-based causes. Sometimes we forget about the little old lady admitted to the hospital, but she takes benzos at home and these are not continued in the hospital. So look for withdrawal. And there's also elderly people who drink and they're not going to tell anybody, but they will go through withdrawal as well. Look for intoxication or anything like that. Also, any stress, any trauma, if they've had trauma and injury, surgery, or any stress. And that can be environmental stress, cognitive stress, sensory stress, psychological stress. These are some identifiable causes that you can deal with. Signs and symptoms, we want to really differentiate delirium from dementia. Remember, it is a sudden onset, whereas dementia is a gradual, progressive onset. You're going to see fluctuating levels of consciousness, confusion, disorganized thinking, altered perceptions, And you can see some personality and behavioral changes as well. We do have, we are very probably more in tune to the hyper alert, hyperactive form of delirium, where the person becomes agitated, won't sleep, has hallucinations, can't concentrate, restless. They may wander, get out of bed. They may become angry, irritable. The one that's missed is the hypoactive, where they're just very drowsy and fatigued. Just kind of slow, depressed, their speech is a little off. This one's more easily mixed. Other people do present with mixed symptoms. They're disoriented, they may have some antegrade, retrograde amnesia, but they'll have mixed symptoms where they're sometimes appear in the hypoactive and sometimes the hyperactive. These are important to know because even though you're not working in the acute care setting where this is most often will occur, it can happen at home if someone's very sick. And also, even if somebody's loved one is in the hospital and they start acting like this, they may call you, the primary care provider, say they're doing something to her at the hospital. I don't know what's going on. And so they need some education. And also because there may be some longer term, it may take a while for it to clear. They need some education when the patient goes home, some reassurance and things of that nature. Your gold standard for delirium is a full assessment by a mental health expert. However, this does not often happen. There are, in the inpatient setting, there's the confusion assessment method, ICU version, the CAM delirium rating scales. There's several rating scales that are used in the inpatient setting to determine if, this is a possibility. We're going to talk about prevention, even though, again, you're not in the acute care setting. This is something you can teach your family. You can teach the patients if they're going in for a surgery or something like that. You can teach them this. Make sure that they have the right lighting, that it's dark when it's dark outside and light when it's light outside. Provide verbal reorientation, family, friends, people to visit, but not overstimulate. Make sure that they're getting the correct sleep, that they're getting out of bed early. Don't forget to take their hearing and visual aids to the inpatient setting. And this goes at home too. Sometimes if somebody's being treated for something at home and they're pretty sick and they're just laying there, same thing. You tell their families the same thing. Hey, keep them on a schedule. Turn the lights on in the daytime. Talk to them. Make sure they put their hearing aids on, their glasses on. Get them out of bed and sit them in the chair. Avoid things like antihistamines, benzodiazepines, and opiates, as these can increase these symptoms. However, on the other hand, if they are having pain and are not managing it, this can exacerbate delirium. Make sure that you educate your family and the patient to watch for alcohol or drug withdrawal. They need to be educated. And we often forget to ask elderly patients about their drinking habits, but there's, the sweet little lady who you find out is drinking 4 glasses of wine a night. That can be a problem. And so what do you do if this happens? Of course, we want to, first of all, treat the underlying cause. Look for infection, for any fluid and electrolyte imbalances. Make sure they're having adequate nutrition and pain control. Look for drug toxicities. Make sure their bowel and bladder is functioning correctly. Make sure they're safe in case they are having some behaviors. You want to reorient them, use their family support. Drug therapy is a last resort, and you always want to use a low dose, but what we usually use is chlorpromazine, risperidol, Seroquel, or Haldol. They use something else in the intensive care unit. When you're reorienting them, again, clocks, calendars, pictures of the patient's family, things like that to help them know who they are and what's going on. There are some long-term consequences of delirium. Only a third of patients who had experienced delirium were still living independently following the episode. So it can lead to some long-term things. Even though we say they last no more than a month, it can last up to 12 months or longer. It is associated with an increased rate of cognitive decline in those who have underlying dementia, and increased mortality rates related to delirium, 14% and at 1 month and 22% at 6 months. So it does have some consequences. All right, we're going to move to dementia. One thing to remember is that dementia is not a normal part of aging. Normal things that do occur, we do have a decrease in the number and size and the number of neurons, and the brain size and weight does decrease to some extent as you age. There is some delay in processing and retrieving information. Those are normal, but dementia and those signs are not normal. Your goal with dementia is that you want to recognize it early, treat it, and to optimize their functioning as long as and as best as you can. This dementia, it is estimated that by 2050, there will be 135 million people who have dementia. It is characterized by a loss of memory that disrupts your daily life, not just an occasional forgetfulness but it's disrupting your life. They have challenges with planning anything, with solving problems. They may not be able to complete a very familiar task. Get confused with time or place. They have some issues with visual images and placing things in space. They may have developed new problems with words in either speaking, writing, or both. Losing things, they can't follow their steps back to say, where was this? Judgment may become a challenge. They may start to withdraw from work or social activities. And they may have changes in mood or personality. These things may happen early on and are often not attributed to dementia or kind of missed. Other things you'll see, again, as personality changes may occur. People may get paranoid, they may become very different. And then you'll see some behavioral problems, some irritability, eventually agitation, delusions, wandering. And this leads to, an inability to work, an inability to fulfill their family and social responsibilities, and eventually to perform their activities of daily living. We're going to talk about the different causes of dementia. We have neurocognitive disease, and this accounts for about 80% of cases. And don't forget, I don't even have one here, but there's mild cognitive impairment, which is kind of a precursor to dementia. 17 to 20% of people with mild cognitive impairment do convert to dementia. Alzheimer's is the most common. We have Lewy body dementia, frontotemporal lobar dementia, Parkinson's, HIV. There's several, but you also will see people who have people with Down syndrome or ALS, HIV are also more likely to have it. We have vascular disorders. This can be a brain lesion, multiple infarcts, a brain bleed. Risk factors for this include smoking, atrial fib, hypertension, coronary artery disease, metabolic syndrome. Your main treatment for vascular disorders, of course, is to prevent future strokes with aspirin, Plavix, controlling blood pressure. There's some metabolic things that can cause dementia, including things like long-term alcoholism. This is also known as Wernicke's disease, long-term use of narcotics, not having your thyroid, having thyroid dysfunction that's not treated, hyperglycemia, hypercalcemia can all lead to dementia. And then there's other things that we look at, things such as a tumor, seizure disorders, lupus, MS, TBI, traumatic brain injury. All of these can lead to dementia. So what do you want to do? You really want to establish a good cognitive baseline with your geriatric patients so that you can prepare for later. The mini cog is one where you just we call and draw a clock. The mini mental status exam we're well familiar with. But there's some others. There's Milner's verbal fluency test. There's the St. Louis University mental status, the Montreal cognitive exam. These are all some of the different things you'll see used in different offices. The 88 dementia screening interview. This is an interview where you ask them questions, which is a little different from a mental status exam. But it kind of gives you their subjective feelings about how they're doing cognitively. It's brief. It can be used as a screening tool. 2 or more yes answers are highly correlated with dementia. And patients serve as their own control with this particular form. It doesn't seem to be affected as much by education, age, gender, or race. 85% sensitivity and 86% specificity. So a really good screening tool. The Milner's verbal fluency test is another one. It's simple. Basically, it's done by naming grocery items or as many animals as possible in 60 seconds. And anything less than 15 represents an impairment. Monitor them to see if they're categorizing, like naming all pets, and make sure they're not repeating things. Then we, of course, have the mini cog, where you're having them draw a clock and naming 3 items that you've said to them. If they do well with all that, they're not impaired. If they can't recall anything and their clock is abnormal, they're impaired. And then you can get people that are kind of in the middle there, with that they're a little bit harder to tell. The SUMS examination is another one. SUMS does stratify for education, so that's something a little special and different about it. I like the Montreal cognitive assessment to go a step farther from the mini mental. It has a really high sensitivity, and there's 3 versions that stratify for education, and it is free online. So when you're assessing, diagnosing this, first of all, you want to look for the cause. Is there a reversible cause that might be the problem? You want to look for other disorders. You want to do their mental status exam. Make sure that you do a thorough review of their medications. Look for other things, look at their labs. Could they have a B12 deficiency, which may be impairing their memory? Is their thyroid out of whack? Do a urine drug screen. Do a good thorough exam. If you also want to, if they're having a lot of symptoms, you want to do a CT or MRI to look for vascular brain lesions. You also need to do not only a good physical exam, and that's important, also behavioral assessment, look for depression, anxiety, irritability, any agitation or aggression. 50% of those with dementia do have co-occurring depression. As part of your assessment, you always, besides the behavioral assessment, the mental mini exam, you want to make sure that you do a good assessment of their functionality, what their environment that they're living is like, and how is their caregiver doing with this. So you want to make sure to look at all those elements. You also want to screen anyone with dementia for depression. There's a special one. We can use the PHQ-2 or the PHQ-9, but there's a special one for depression with the dementia called the Cornell Scale for Depression. The PHQ-2 is a really simple one, depending on what their cognitive level is that you can use. Before we start getting into Alzheimer's, we're going to briefly discuss the other forms of dementia because you're going to see these two. And sometimes people will have two forms of dementia. So vascular dementia is caused by either ischemic or hemorrhagic brain injury. And it's usually a more abrupt onset, and it's kind of a step-by-step ladder approach we'll talk about in a minute in their deterioration. They'll have times where they seem very cognitively intact and times when they aren't. You may see some focal neurological signs and symptoms and evidence of cardiovascular disease. So risk factors, of course, are hypertension, diabetes, hyperlipidemia, advancing age, more common in males and more common in the Caucasian population. Common features, issues with word retrieval, verbal fluency is one of the first things you'll see. They will eventually have some issues with impaired motor programming, executive function. Perturbation is a persistent repetition of a word, a phrase, or a gesture. They may become disinhibited or have almost manic type behavior, or be very apathetic with mood changes and can have some obsessive compulsive behavior. So a lot of little behaviors with this form of dementia. The one thing that stands apart, that makes it kind of stand apart, it's hard to tell with AD, is in Alzheimer's, the decline in function is very steadily, they go down. But in vascular dementia, you'll see them kind of plateau out, and then they'll have a drop in function and then plateau out. So it's a little bit different progression in their decline. Lewy body dementia is caused by the presence of abnormal proteins in the brain called Lewy bodies. One of the things you'll see is, it's an early visual impairment in the absence of any other significant memory loss. So the other symptoms will occur first. Eventually, it does affect the cognitive, sensory, motor, sleep, and autonomic function. You're going to see cognitive fluctuations where you may see Parkinson-like symptoms and visual hallucinations. That's a big telltale sign of Lewy body dementia. You may see some issues with sleep where they're sleeping in the daytime but up at night, and nightmares are common. They are very highly sensitive to anticholinergic medications. Robin Williams is somebody who did have Lewy body dementia. He had a lot of periodic delusions and hallucinations and some issues with movement as well. Parkinson's dementia occurs in 20 to 30% of those with Parkinson's. It's usually preceded by the physical decline, and the cognitive decline comes later. They also have very similar symptoms to Lewy body in that they have the hallucinations. They also are prone to depression, but they have less agitation, disinhibition, and irritability than Alzheimer's patients. Frontal temporal lobe disease, or Pick's disease, is when you have a degeneration of the frontal temporal lobe, and the hallmark feature is behavioral symptoms. They will have a lot of disinhibition, aggression. They may have issues with social skills, poor hygiene, apathy. They can't judge or reason well, issues with concentration, and emotional lability. It has an earlier onset, and it's also often misdiagnosed as a psychiatric disorder. Prognosis for frontal temporal degeneration is pretty poor, 6 to 8 years. And the medications that generally treat other forms of dementia aren't ineffective. Normal pressure hydrocephalus is when you have an excessive cerebrospinal fluid accumulating in the ventricles of the brain. This one, the big thing is they present usually with gait disturbance and urinary incontinence along with a cognitive decline. The big thing with this is that they'll take these wide, kind of small shuffling steps. The big deal with this is early recognition because it can be treated with shunting with no permanent damage to the brain. If this diagnosis is missed, then they will permanently damage the brain. And I do have a family member with this, and they lived in another state, and this was not diagnosed, and they have permanent damage, and it's pretty sad. So look for this, be aware, to look for that telltale sign, that gait disturbance and sudden urinary incontinence when they didn't have it before and they're a little off. Don't be afraid to check for this. A CT can always tell you. So important to do. We're going to stop there before we start Alzheimer's and go wait for the next recording.